So first and foremost, I'd just like to say hello to everyone and welcome to our very first virtual town hall. We're so pleased that all of you could join us today for the OPO Transplant Center Outstanding Collaboration Success Showcase. My name is Deanna Fenton, Program Manager here at the Alliance. Now, before we begin today's presentation, I would just like to take a few minutes to review the details of the program. The Alliance Virtual Town Hall Series was established to highlight successful OPO and transplant program relationships and the resulting donation and transplant outcomes. This virtual town hall will focus on effective collaboration and communication. Now, you may have noticed that your audio lines have all been muted. We will keep the lines muted for the duration of today's presentation. During the Q&A period, we will ask that you submit all of your questions using the chat feature, which is located at the bottom of your Zoom browser. If you do have any questions that come up during the presentation, please feel free to submit them using that chat feature. For your reference, there will be no continuing education credits that are offered for today's program. However, all participants can claim a certificate of attendance. Following the conclusion of the presentation, you will receive an email from Alliance team member containing the link to the program evaluation and certificate. As an added note, we will be recording today's program, so you can view the recording of the presentation and register for future town halls on our website at organdonationalliance.org. With that being said, at this point, I'd like to get the program started and introduce our moderator, Christina Wheeler, Transplant Administrator at One Legacy. Christina, thank you for joining us today. At this point, I'll turn it over to you to introduce our speakers.
Thank you, Deanna. Thank you, everyone. Thank you for joining us today. So I would like to introduce our speakers. Judy Poserli is the Quality Coordinator for Las Palmas Medical Center in El Paso, Texas. In this role, she oversees all QA/PI activities for the program and develops performance improvement initiatives for the program in collaboration with the inpatient setting and their outside agencies and partners such as Southwest Transplant Alliance. She's been employed at Las Palmas since 2012. Prior to this, she was an outpatient dialysis facility administrator, clinical manager at both DaVita and FMC, and a bedside nurse and a manager of inpatient renal patient care services at Sierra Medical Center. She obtained certification in nephrology nursing in 1998. Judy earned a Bachelor of Science in Nursing at New Mexico State University in Las Cruces, New Mexico. She's a member of the American Nephrology Nurses Association and the American Society of Transplantation and the National Association of Transplant Coordinators. Our second guest speaker today is Yvette Chapman. Yvette has been in transplant for almost 15 years. She's been employed with Southwest Transplant Alliance for 5 years and has served as the Director of Quality. And for the past 3 years, created a new role as the Director of Transplant Center Development. In this position, she provides ongoing support, consultation, and education to the hospital transplant centers that are STA's partners. Her mission is to build rapport and foster collaboration between the organ procurement community and the transplant center community. Prior to joining STA, Yvette was a clinical operations at the Dallas Nephrology Associates, where she has served as the office practice manager. With more than a decade in healthcare, Yvette began her career in organ transplantation, working as a nurse at Methodist Dallas in the transplant unit. She later became the senior transplant coordinator at the Liver Institute at Methodist Dallas Medical Center. Yvette earned a Bachelor of Science in Microbiology from Louisiana State University in Baton Rouge, Louisiana, and a Bachelor of Science in Nursing from South University in Atlanta, Georgia, and is currently working on her master's in nursing from the same university. She's also a certified clinical transplant coordinator. Yvette is a member of the Association of Organ Procurement Organizations, serves on the UNOS Transplant Administrators Committee, the American Society of Transplantation, the American Nephrology Nurses Association, the Organization of Transplant Professionals, the Texas Transplant Society, and is the former president of the Dallas chapter of the International Transplant Nurse Society. Thank you to our speakers for joining us today.
All right, well, welcome to everyone. We are looking forward to sharing the relationship that we have had, we being STA and Las Palmas, with you. Thanks to Judy for submitting some of our wins for us to be able to share this with you. So with that, we will get started. So for many of you who don't understand the geography of the state of Texas, it is quite unique. The state is divided by 3 different regions. We have 3 OPOs in the state. We have Life Gift, out of Houston and Texas Organ Alliance out of San Antonio. And as you can see, there's no real rhyme or reason to how the state is divided. With that, it creates a very challenging geography. And as you can see, the star on your right is where the headquarters for Southwest Alliance, Southwest Transplant Alliance, and to the furthest most reaching part of the state of Texas is where one of our famous transplant centers, Las Palmas, is. And as Judy can speak to, the distance is how far?
635 miles.
Which makes it a bit of a challenge for not only the donation side, but also logistics for the transplant process in itself.
Ready? Okay. Good morning, everybody. Thanks so much. So just a little bit from our side, challenges for us here in El Paso, location. Like Yvette was saying, we're 635 miles away from Dallas. We're pretty much the only transplant center for about 250 miles out here. Albuquerque and Phoenix are probably closer to us than Dallas. So, you know, we have to be super careful. We don't have a lot of nonstop flights here to El Paso. So, you know, if a kidney's available after 6 p.m. at night, it's not getting here till the next day. So we have to be really sure that we've got a solid plan in place before we start flying kidneys around the state. I think we calculated at one point that we were adding about 7 hours of ischemia time just in flight logistics. So that was a real challenge for us.
And we on the OPO side have the same challenges, especially if we have a donor in the El Paso area to get our blood back to Dallas for our HLA and for serologies. We have to make sure we catch that last flight, or if not, that's going to be the next day before we're able to do that.
Right.
Since we are Dallas is our central hub, we do have an office in El Paso, but that's everything else goes through Dallas. And so it is very, very difficult, especially if we have a kidney that's procured in El Paso, but they're not primary at the time. And it has to go back to Dallas oftentimes prior to some of our relationship buildings. It was having to go back to Dallas to be put on the pump, and you can't fly pumps due to the lithium batteries. So then we would have to drive those kidneys back to El Paso. So it had, in the early days, it had been a lot of challenges for us.
Right. Yeah. That was a huge frustration for us that even a kidney procured locally would go back to Dallas and then get flown back to us later on once we became primary. So that was the situation. We also have two surgeons with very different acceptance practices. I joke around that, you know, we have one conservative and one liberal surgeon. So depending on who's taking call that week, our organ acceptance varies quite a bit. And so getting them to buy into this whole thing with these logistics and needing to be sure about what you're going to accept and decline was a little bit of a struggle as well.
So in the beginning, when we started this collaboration, we each set goals for ourselves and for our organizations.
So one of our biggest thing was to decrease our offer declines. We were having not a huge organ decline rate, but we wanted to make it better and keep as much as we could local if we could.
And for us, we were really wanting to increase kidney utilization for those organs that we were able to keep within our DSA. And the only way to do that was to be able to get together and look at why Las Palmas was having the type of declines they were. So it's really about digging into the information to increase that utilization.
Right. We want to decrease wait time on our list. We don't have a terrible wait time here at Las Palmas. We're right at about 2 to 3 years, where the rest of the state is about 4 to 5 years. But we always want to make that time better so our patients aren't waiting so long. So.
And for us, because of the logistics in the state, we were trying to do the best that we can to expedite organ placement so that we could reduce the cold ischemic time, because these were some challenges we have had as many, most of us have for years. So we really wanted to establish early on that being one of our goals.
Right. Of course, like any transplant center, we want to increase our transplant rate. When I started here at Las Palmas, we were doing about 20 a year. Our highest rate was actually in 2017. I think we did 40, and last year we did 34. So we've pretty much doubled our volume.
And us too. We wanted to see the increase in the transplant rate. It's, I mean, it's, of course, you know, we have organs that are available, and we want to make sure that these organs are transplanted and not discarded due to cold ischemic time or just logistics in itself.
Again, like I said, we want to keep our local kidneys local if possible. And just a note, we are working with, our average cold ischemia time here at Las Palmas is about 24 hours. So we've got quite long ischemia times. And so if we can keep a kidney here and not have to ship it out, we'd like to do that.
And the other big thing that was a goal for us in the beginning was understanding the acceptance practices of especially Las Palmas, because they did differ so much between surgeons. And the only way to do that was to be able to have some hard conversations within the program. And ultimately, together, our final goal that we worked to get was to develop an effective line of open communication between Las Palmas so that our issues, we could solve those much easier and much quicker.
Right. Yeah, I think that was a good mutual goal that we had. I think we both were coming at the same end point from different directions. So it was good we were able to get it together.
So we wanted to look at what the advantages of the relationship between the OPO and transplant center collaboration were. And for both of us, it was about identifying areas of process improvement. Anytime you can sit together and have a conversation, it's not a pointing the finger, it's more, oh, absolutely, we could have done something better. And so we were able to identify areas, something as simple as not uploading the images of the kidney to DonorNet early enough, or getting the photos of the biopsy slides, or even imaging in CompuMed. So we identified early on areas for the OPO improvement. And certainly I know that Judy can speak to some of the areas that they were able to see as well.
Right.
And then we also wanted to create and implement effective strategies for both of us to see how we could optimize organ utilization. And a lot of it, like Judy's already spoken to, is about reducing the cold ischemic time, because if we could do that, then we knew that we could possibly be able to get these kidneys transplanted much sooner. And obviously ensure compliance across the board with all of our regulatory agencies. So we started working on some of our strategies.
Yeah, so back in 2015, Yvette showed up and we invited her to start coming out to our QAPI meetings. I'm sure like everybody else, there's nothing I hate more than a wasted meeting, and I can just sit there and throw data at you. But if we're not going to do anything with that data, and we're not going to actually do the PI part of our QAPI, the performance improvement part, then, you know, it's hard to keep people engaged in those meetings. So we invited Yvette to come out to start talking about the OPO side of transplant, which we don't see very often on our side. Go ahead, Yvette, that's yours.
So based on our meetings, we started working with UNOS, myself and Meg Rogers, in Minneapolis, we started working with UNOS to develop a mechanism where we could show opportunities where organs were declined and what their outcomes of those were, because that's the feedback we were getting. So as a partnership, we worked with UNOS to develop the organ utilization tool, which basically, for those who don't know, it gives you a customized view for organ offer review process that has long-term outcomes, 6 months and a year of long-term outcomes.
So what we usually do is Yvette comes, I present my piece of the QAPI, and then the next piece is Yvette gets out the organ utilization tool, and then we review any offers that we've declined. Why did we decline? And then whether those organs were eventually transplanted and how they're doing. Are they having delayed graft function? what was the discharge creatinine, the length of stay, those kind of things. We had to kind of get our on-call coordinators to be a little more detailed in their documentation when they're documenting why we declined the organ, not just an 898 code and that's it. They've got to get in there and say, you know, the biopsy results or the terminal creatinine or whatever the reason was, because there's a delay in this date, and I think Yvette's going to talk to this. And so, you know, I don't remember what we did in January. So we need to have really good notes so that we can make it a really effective review.
And it's always fun when they get their call schedule out so they know which surgeon was on call. And that was one of the things that came out, because they were questioning, well, who declined that? Oh, that's who was on call that day. So that's always a little, for me, a little uncomfortable to sit there where they're having to, the surgeons are holding each other accountable for this, for their decision-making process. So that has been very instrumental for their program to determine these things.
Yeah, and like she was saying, surgeons, you know, surgeons being surgeons are just a little competitive by nature. And so they really started getting into this part. And I always laugh because I tell them, hey, don't forget Quappies next week. And first thing they say is Yvette coming? So it really—
And it's not because I bring breakfast.
Right, no, has nothing to do with that. But it really made them look at their decisions and discuss it. And I would have accepted or I would have declined. And why? Why do you say that? Oh, yeah, now I see your point. So it you know, it really became a good dialogue between the docs, and even the transplant nephrologist will chime in sometimes about the medical side, about why he would have suggested to either accept or decline. So it's been a really good addition to our QAPI meetings. I try to keep note of organs that maybe we've declined and the surgeon kind of was on the fence about it and then decided to decline, because those are the ones that they really want to look at the next time she comes out. So we can see, was that a really valid decision or was it not a valid decision?
Yeah, and oftentimes that is. We were able to show that delayed graft function is higher in the organs that they declined versus the one they accepted. So sometimes it's just validation that what they're doing for their program is spot on.
Right, exactly.
And then it also gives us the strategies, real-time review of issues. Oftentimes there's been a problem with the procurement that we need to address. And by having this kind of relationship, that strategy has been able to help all of us to make effective changes in our practices about what goes on in that process.
Right.
So before we started doing things the way we did, this was probably a little bit how organ offer review process went. And so we hope through the whole piece that we may have made some changes, and the new changes are reflected here. So what we use is the organ utilization tool that shows outcomes of declined organs, like we spoke to, as well as in specific with the decline codes, which really helps us understand. It also helps provide accuracy on the transplant center side with respect to putting the right decline codes in. And then we have routine data review outside of the normal scope that Judy does as well, because we are able to bring a lot different pieces and tools to the table to now review organ offers. It kind of looks like this. For those of you who haven't seen it, this is just a snapshot. This is a snapshot of what we can show as their acceptance rate. And when I talk about bringing the schedules to the meetings, Judy can speak to this, that we can go down into, oh look, June 16th, we had a 33% acceptance rate. Who was on call then? And so we can get to a very granular level, and then the center can dig in and see what was going on. Was it a vacation going on, or we really just didn't have the patients that we wanted to transplant these kidneys in? And then we can also, through this process, go into a little bit more in depth about the individual offer itself, what sequence the transplant center were doing the review with, where their patients were, where the organ was transplanted at, and then really dig into, was it right for that patient? Should they maybe look at it a little differently? And then ultimately the outcomes. If we don't have outcomes, it's not going to help, because it doesn't help them to review an offer without going, well, you know, what's it doing at 6 months? Yes, the creatinine was 6 at discharge and they had some delayed graft function, but now at a year, we're back down to a 1. So, but we passed on that for all of our recipients. So that's a very great opportunity we have to share and work through some of those processes.
So I went back and looked for our center, just kind of looking at STA offers only, and these are rough numbers, so don't calculate the math, but kind of our acceptance rates versus our transplant rates. And so if you can see, the light green bar is how many kidneys we were actually offered during that time period, and then how many we accepted. And I went 2015 to 2018. And then how many we actually transplanted. And you can kind of see it grow. The point of the slide is to kind of see how it grows over the years, that we actually have improved our organ acceptance rate through this review.
Oh. I don't know where it went. Sorry about that. And then for us, we follow our imports and our exports, where they're going. Now we know in the light of the change in allocation that will be coming soon, there will be, you know, trends on how this is going to look. But if you can look from 2015, you can see how many of our kidneys we are exporting. And this was not all due to just mandatory allocation. There was a good portion of these organs that are being transplanted elsewhere that had been offered locally. So you can see there was like 169 kidneys that were leaving RDSA, and a good portion of them were directly related to being declined locally because of the acceptance practice and the utilization within our centers. But if you look at what happened in 2018, you can see the drop. We were only exporting 22% of our kidneys at that point in time, and our utilization locally had improved by 6%. So through our collaboration, we had some very, very positive outcomes.
Yeah, so I went back and looked at 2015 to 2017, and we actually had a 6% increase in our organ offer acceptance rate just for STA organs. But of course, it affected offers from outside OPOs as well, because it really changed our whole offer acceptance paradigm, I guess, for lack of a better word.
And for us, we had an overall 8% decrease in exported kidneys and a 6% change in those that were being offered locally first.
We had a total 10% increase in transplant rates just for STA organs for those 2 years as well. And of course, an increase for the other OPOs too. One of the first things that came out of this review is the surgeons decided to sit down and change our donor selection criteria. It turned out we hadn't looked at it in a while. We had a pretty narrow acceptance. So we were finding that we were not even being offered some kidneys because of our donor selection criteria. So we really opened up our donor selection criteria, and that helped as well.
Yeah, that process was quite interesting because we were able to really sit down, because we've developed a relationship, and say, okay, so we're not getting offers. And they would say, that you're not giving us the offers. And that was, like Judy said, was the first thing. Let's see why. It begins with how you list your donors. Right. And there were things where they had set their BMI at a level that was far below what the average BMI was for one of our donors for a period of time. So once you started making some changes like that, it made a huge impact.
Really did. And then so we were talking about collaboration on, you know, the other kind of logistics issues. So one of the things that we were able to do was get kidney pumps actually here in the office for STA in El Paso, because previously, like we were saying, kidneys had to be flown to Dallas, get put on the pump, and then come back. And so now we have the option that we can pump kidneys here. Even if we're not taking the kidney, it can get pumped here and then shipped out. So.
And the nice collaboration that came from this, not only did we train, our STA does have an office there, so not only was it our STA staff that was trained about putting kidneys on the pump, several of the staff from Las Palmas came to our STA office because they were interested in learning about, you know, putting the kidney on the pump and what happens when there's an error message that goes off. Right. And I think that was a very unique situation, one that in our area we had never experienced. So we were very, very pleased with how that outcome.
And so another thing that came up recently was we had a donor at one of our local community hospitals, and I don't even remember how we found out, but STA was having a hard time getting a biopsy done. Something about pathologists not being available and all those things. And I brought up to Yvette, I said, well, we have a pathologist here in town that does our biopsies, and he's awesome. I've worked with him for 30 years. And so we did reach out to him, and he has agreed to do the local biopsies for STA so that we can expedite that process. And so instead of a 2 hours to get a biopsy back, we can decrease that time and get those organs allocated earlier.
And that was a huge win, especially with the logistic challenges that we have just because of the geography.
Right.
So as you know, we've gone through a lot of things really quickly, but just in a few short years, I think the progress that we made with establishing a strong relationship and being able to just pick up the phone and say, hey, Las Palmas, what's going on? Or STA, what's going on? How can we build on this? And I think it's been a win for all of us.
Yeah, no, I think it's been a really good collaboration. And it is nice to know that real time, like she said, like today, if we went to surgery and the surgeon tells me, take a picture of this ligated artery or whatever it is, and then I can just shoot the pictures to Yvette, and then she gets with her surgeons, and we've got some real-time resolution of some of these issues, and it's worked out real well, I think.
So with that, we certainly would be willing to open it up to questions. If anybody has anything, we're available.
Thank you, Judy and Yvette. Before I turn it back to Christina to moderate your questions, I'd just like to remind everyone that if you do have any questions for our presenters, please submit them using the chat feature. For those of you who aren't aware, it's located at the bottom of your Zoom screen. Right at the bottom, it should say chat. So if you just click on that, you'll be able to type in your questions and we'll be able to address them. Thanks.
Thank you. Okay, so we do have a question. So how do you feel the recently approved board action on expedited organ offers will impact you?
As a transplant center, I mean, I think it's going to work in our favor, being that we're so distant from everybody else. If we can expedite offers, that would be, I mean, best in our interest. I don't know how it affects Yvette's side.
Well, certainly for us too, because obviously, if we're trying to move an organ from, let's say, another part of the state of Texas to El Paso, if we can weed out those other reasons why a certain center never accepts an organ, and we can get that because we know Las Palmas will, and get everybody else out of the queue, it certainly would reduce cholestatic time and hopefully ultimately the function of that transplanted kidney.
Yeah, absolutely.
Thank you. So another couple of questions. Are other OPOs doing offer reviews like STA? Do you know of other OPOs that are doing this, Yvette?
I know that Life Gift is, and I think TOSA, and I'll speak for Region 4 right now. It's a little bit slower for them because you got to remember I started this process, and then of course Meg Rogers at Life Source is doing it too. And everybody's unique. Your own areas are unique. And of course, I have 11 transplant centers and 29 programs, and each one of those is completely different. But we do organ offer reviews in every one of them, just at different rates. But I do believe other OPOs are starting to do it. it just seems to be, they're a little bit having a little, I don't want to say challenges, but it's just been a little bit slower to get to that process.
Thank you. So Chad did share that Live Share in Oklahoma has started this as well, with the emphasis starting towards the end of the year. And One Legacy, we also do this. I think one of the challenges we have is the timeframes of the data. And so I think that's one of those things that for each program, it's kind of different what they want.
Yeah, very true.
Chad, yeah, absolutely. Chad has another question. What mechanism did you implement in the Transplant Center to flag cases of interest? Those offers that the transplant team goes back and forth on and want to look at later?
Yes, a lot of those. Even though, you know, I don't just sit in my office and do quality, I'm kind of out in the middle of everything. We still go to surgery as coordinators. And so I've stayed on surgery call just to be involved in that. So if I see something that triggers that, or the on-call coordinators know to shoot me an email or a text or something and say, hey, you know, let's look at donor XXX, whatever it is, when Yvette comes out next time, so that we can look at why, because, you know, the surgeon declined and we think they shouldn't have, or the opposite. We accepted and we were kind of hesitating. We wondered why. So it's not a real formal process at this point, but it's working, that I'm getting those offers. Also, we also flag those that, you know, we're held to the UNOS reporting times. And sometimes centers don't report real timely. And so we may look at an offer and the discharge creatinine hasn't been documented yet, or the 6-month outcome or whatever. We'll make a note to go back to that one the next time she comes out so we can capture that.
I've had another center actually will put a flag on maybe like an Outlook calendar.
Uh-huh.
So in particular, if you had like a central CNS tumor that had not been manipulated, and so we did proceed with donation on that, but for whatever reason they decided not to accept it, we have had programs put that on their Outlook calendar to look back in 6 months and a year to see if there's any additional follow-up. So everybody does it a little differently. For a while I was trying to keep up with it. It was just too much for me, so then I put it on to somebody else, the quality manager, the whoever in the room, to say, okay, however you want to track and trend this, let's do it. And then when that time frame comes, then we'll go back and reevaluate it.
Right.
Okay. So Yvette, I think this question is mostly for you. 0 antigen matched kidneys procured at your OPO. Does your program export the kidneys without final cross matches done?
Well, actually, we just had a discussion with Las Palmas not too long ago about that.
Yeah.
We would prefer not to, unless we are really confident that the accepting center, especially if it's going a distance away, is going to be able to utilize it based on their virtual. So, and Las Palmas, is this correct now, Judy? You guys go to the OR with the virtual?
Yeah, we just recently changed our policy and we're going to surgery on a virtual. We have, you know, parameters set up. I mean, if it's 100% PRA, we're not going on a virtual, but for those straightforward cases, we can go to surgery on a virtual.
Thank you. So can you talk a little bit more about reviews of the problems on the procurement side, such as surgeon issues? Yvette, how do you guys work with those, and do they become like events, or how do you communicate those issues?
Well, it certainly kind of depends. Oftentimes, when we, and especially if it's a surgeon issue, a surgical event, I will do everything in my power to bring the peers together. And so we have our own in-house recovery surgeon who's also our medical director. And oftentimes, if he can't go with me to a meeting, we'll have him on the phone to actually speak to what the event was, whether he procured it or whether it was another center, and what those discussions are. So it's going really well, but it's about having the right people in the room at the right time, because I'm certainly not the one to speak to, you know, the surgical damage, unless we had to follow up. If we had an RCA that we needed to follow up on, then I'll do that. And if that's the case, I may even bring our quality manager into the discussion to speak to it from their perspective. So going over those issues sometimes can be challenging, but it's about having the right team together at the time you're having the discussion.
Right.
Good information. Thank you. So Yvette, can you tell us who did STA work with in the transplant centers to get this process started?
So in the very initial days, I went through the internet logs and got the names and contacts of all of the transplant administrators and every one of the programs. And then we drafted from our CEO, Patty Niles, we drafted a letter saying what we wanted to do, what our purpose, what the role was going to do. And she and I went out to each one of our transplant centers and met with them so that the transplant centers didn't feel like we were, like the OPO was trying to direct the way they practice medicine. That was not what we wanted to do. So it was about making sure that you get the right person. And the right person is your transplant administrator to say, okay, we want to have meetings and we'd like to meet with your surgical and transplant teams. And this is what we want to bring to the table to open that line of discussion. So it was a lot of legwork for me to be able to identify in each one of the programs because I didn't even know. I knew 4 or 5 of the programs, but I had no idea. Certainly had not been to Corpus Christi, which is at the south end of the state, to a small children's program, and I had not been to El Paso for those meetings. So it was a lot of legwork, but again, it was just getting the right name because you can't just pick up the phone and think that somebody at the front desk at the transplant center is going to go, oh yeah, I'm going to set up a meeting, and this is who needs to be there. So it was about establishing that line of communication as well.
Great, thank you. So I do have a message here. Life Center Northwest has had good results with this approach over the past 18 months. Overall kidney utilization has increased, local kidney transplant rates have increased, and overall collaboration has improved. There's a shared focus on performance improvement, grounded in data, and that has been the key. So that's a very good statement. Thank you for sharing that. I believe that was Kevin O'Connor. The next question I have is, do you as an OPO capture more detail on 830 declines to gain a better real-time understanding on why centers decline kidneys?
So one of the things that I have educated every one of the programs that I do reviews with is that anytime they enter an 830 for quality age, to always enter an 898 to where they can free text. Because once they can do that, then you have a detailed information, you have the detailed information as to exactly why that organ was declined for that reason. I have one center, if there is an 830 put in and they haven't put an 898, they get very, very upset, the surgeons do, and they will call each other out on, well, why didn't you do this? Because this is no good to us. Because then we have to start digging into DonorNet and to try to figure out, 6 months later why they declined an organ that otherwise today looks good. So it was just about educating. So that's what I do every time, and it's a huge change. Yeah. And actually, I was just there in El Paso on Tuesday, and we kind of gave one of their coordinators a hard time because there was not that information on there. And so it was, they all hold each other accountable. And maybe one day, we've talked with UNOS several times about as they do their reprogramming to be able to add a free text box on every decline code, not just an 898. But that's what I do. Put an 830 and then put an 898 and get that real information so that it makes a retrospective review useful.
Thank you. Yvette, can you tell me, and Judy, do the transplant centers have any access to the out report?
They do not. They don't have access to the out report, but going forward, UNOS has created a version of that specific for the transplant center. So they not only have their local OPO's information, but will have all of their data, because as allocation changes continue to do so, they're going to need that. And not every, I think there's about 10 or 12 people right now that are in dedicated roles like this of mine. And so that's not very many people across the country that can go out and share this information. So I worked, Meg and I worked with UNOS to help them be able to create something, especially for transplant centers that don't have the opportunity to have the relationship that we have to go in and work on it.
Thank you.
I think it's called the CARE, if I'm not mistaken.
Oh, the CARE. Okay.
I think that's what it's called.
Okay. Let's see. Were there any concerns about sharing others' data or sharing data because transplant centers are, let's say, competitive to you? Was there ever any concerns about sharing the data that they may see other centers' data, or have that competitive nature about them?
Well, I'll let Judy speak from the transplant center side, but I saw Rodney Cruz was on the phone, and he's in the same role in out of Houston for Life Gift, and I know that he runs into this problem. I've not run into it with our transplant centers because they know if I'm transparent with what I'm showing them, that I'm doing the same thing on the other side, because they are very competitive. Now, I don't show them individual offers of somebody else, but I will show them the comparison of their acceptance rate to another center's acceptance rate. I don't show them the DGF levels of somebody else or DGF rate of another transplant center, nor do I show their graft failure rate, which ultimately you can find on SRTR. But at this level, that's not what I'm there for. I'm here to help them. They didn't necessarily, initially they were a little hesitant about it, but then they just dig into their own data and they're not worried about the rest of that.
Yeah. And I think Yvette made a good point. It's about looking at global issues, and kind of that more high level comparison rather than a finger pointing kind of thing. It's more like, well, if our DGF rate is higher than everybody else, what's going on? Or if we're better than everybody else, is there something we're doing different that we could share with other people? So I think it's more of that kind of a level of looking at other people's data more than, they should have taken that offer or something like that,
Well, and I was actually questioned early on when other transplants, when other OPOs started getting access to the out. Why would I possibly want to share where that organ was going to? Why would you want to do that? And when I was in the process of working with Meg and Eunice to design it, that was one of the key things we wanted to share, because you may have a transplant surgeon at, Las Palmas who used to work at another program or knows the surgeon at Mayo and said, and continually see them using kidneys or livers that they're not being utilized here, that they can reach out to their peer and say, okay, so what is it going on in your thought process? Why are you continually accepting an organ that I wouldn't touch at all and it's working? So that's when when the out was being developed, that was our thought process. That would help them to be able to reach out to their peers if they wanted to. It wasn't about keeping a hold tight of this information. It was, how can we let them, like Judy said, globally see what's going on, and could there be some process change to it?
Right.
Great, thank you. So can you tell me what has been the biggest win between STA and Las Palmas?
Judy, what do you think?
I think for me, just the openness of the communication. The previous transplant center that I worked at, the OPO was in the clinic like every other day. Hey, what's going on? What are you guys doing? Blah, blah. And that's one thing that struck me when I came here, is like I never saw our OPO. And I brought it up several times, and the answer I got was, well, they just don't come here or something like that. So when the opportunity came up, to collaborate with Yvette and STA, I said, no, let's jump on it because it makes it better for everybody. And I really think it has. And from the coordinators up to the surgeons, I mean, it's, there's no hesitation to pick up the phone, shoot an email, even the docs, hey, here's Dr. Reese's number. You had an issue with the last procurement, call him, so I think that's been our biggest win.
And I think for us is just understanding, because from an OPO perspective, our coordinators they don't get to see the end result very much. And so by having this kind of relationship, they can see what they're working for. And because for an OPO coordinator, they live in the world of death and they don't get to see the end result. So I think being able to have that and being able to share that this is why we do what we do. And without that relationship, it would be very, very difficult to be able to share that.
Yeah, and not just Yvette comes from STA to our meetings, the local staff come our meeting as well and sit in on it. And sometimes I think, you know, on both our sides, it's an eye-opening experience about some of the challenges that we have, or you know, we'll make a comment in our copy about something, and then somebody from STA will pipe up and say, oh, well, we can fix that. You know, I think that's kind of how the pump issue came up. So just that open dialogue is really good.
Yeah, I would agree.
Thank you. With that being said, I do also want to know, because you guys just kind of mentioned that a little bit, that you have people coming from both sides, from the OPO and from the Transplant Center, to these meetings. What is a good target audience for this type of a meeting?
Well, with Las Palmas's meeting, we set it up the way they wanted. They wanted a part of their quality meeting. So in this particular meeting, it is the surgeons, the transplant nephrologist, the dietitians, it's the transplant coordinators, the transplant leadership. Sometimes we've had leadership from the hospital side come. Each one's a little different. I have one meeting that I have with a transplant program, and it's only the surgeons, not the transplant physicians. So it really depends on what your goal, what that particular meeting's goal is. If it's organ offer review, you need to have the staff at the table that are going to do the organ offer review. If it's, Judy and I also meet a day ahead and just go over quality issues that we may want to address later. Sometimes we have meetings where it's just the OPO provides transplant education to the transplant nursing staff to meet a CMS requirement. Right. So there's multiple meetings, and it really just depends on what your target is. Organ offer review is it's a major aspect of it, but it's just one type of meeting that, you know, that can be done. It really depends on what type of relationship you have and how much collaboration you want.
Right.
That's great. That I was just going to ask, you know, what other types of meetings do you have, and what other types of collaborative interactions do you have with your transplant centers? That's really good information.
So, you know, one thing while you're bringing that up, that's been very good that I have found out in this role is that oftentimes you may have a major transplant hospital, but the donation side of the hospital doesn't really know what's going on the transplant side of the hospital, and the transplant center may not know what's going on in the donation side. And we even saw that there in Las Palmas, where we were having a barrier to donation with a particular intensivist, and we brought that, even though there's a fine line to cross, we brought that to the attention, and they were really shocked by that. And that the donation rates were low in the hospital, and what was going on, what was STA doing to bring those donation rates up, you know, making sure we were educating. And if there was a barrier, you could have maybe a peer-to-peer conversation to understand we're a transplant hospital, but why are we having these challenges? So sometimes those collaborative meetings to bring both sides of their house together have been huge too. We don't do it on a regular basis, but whenever there is a hospital collaboration at a particular facility, I'll be invited oftentimes to come and share the transplant data as well.
Thank you. So, you know, we are all very driven for transplant recipient outcomes, both on the OPO side as well as the transplant side. Judy, can you tell me how this has affected your patient outcomes there at Las Palmas?
Sure. You know, I think in the beginning there was a perception from the surgeons. They were a little nervous that we were going to have a decrease, you know, poor outcomes from some of these maybe more marginal kidneys that we were accepting, the higher KDPI scores, those kind of things. So there was a little bit of hesitation. We previously were a single surgeon program, and our surgeon was pretty conservative. We opened up the donor acceptance criteria. They were a little bit nervous, but we started doing some transplants, and we found out there was no difference in our transplant outcomes. So that was just validation for them and encourage them to keep accepting under the new criteria. And now they're a little more comfortable with it. So
great, thank you. So I do not see any more questions from the audience. Is there anyone else that has any other questions? Yvette, Judy, final thoughts?
No, just that this has been a really great experience. I mean, we kind of, I hate to admit it, kind of didn't know what we were getting into when we started this, but doing this presentation and looking back over the years, I think it's been a really good thing, for patients, for staff, great learning experience. And like Yvette said, we've gotten a lot of great education and things like that out of our OPO. So I think it's been a very good little adventure we've been on.
I absolutely agree with that. And I just would encourage any transplant program and the OPOs just to find a way, if you can't have a dedicated department or a dedicated person to come and do this, just try to engage with each other, because it has made a huge difference just in the level of satisfaction that we are able to provide for our transplant partners, because as OPO, we're there to serve them and serve that community, because we all have the same end goal. And ultimately, it reduces a lot of angst and some of the issues that were there before. It's resolved them, because now they know that we can get resolution on either end, whatever the issue is. So I highly encourage the engagement, because it's just a win-win for the recipients all the way around, and for the donor families who do offer that gift to life. And so it's been nothing but a positive road for the last 4 years, and I strongly encourage everyone to get involved with it.
Thank you. I did have a comment come across here, just 1 second, from Meg Rogers at LifeSource, and Meg has the same type of position as Yvette does. You've heard her talk about her helping to design the out. And Meg suggests that involvement of medical physicians, such as pulmonologists and cardiologists, who aren't involved in reviewing the donor organ offers, it's helpful to have them at these meetings, and it provides a helpful perspective to the discussions. So that's just one little other piece of information I wanted to make sure to share with the audience. Meg, thank you for that comment.
Great. Well, thank you. A huge thanks once again to Judy and Yvette for being the brave duo to tackle our very first installment of the virtual town hall series, and for more importantly, sharing your experiences on such an important, I think, initiative. Additionally, I'd like to thank Christina for sharing your time and for helping us to facilitate this OPO and Transplant Center collaboration showcase. And to all of our participants, we thank you for your time, and we wish you a wonderful rest of your day. Thank you, everyone.